Hello, everyone, and welcome. I'm Joseph Choi, healthcare reporter for The Hill. Thank you to everyone joining us today for a deep dive on The Hill Talks, the state of Medicare physician payments. I'd like to thank our sponsor, the American Medical Association, for their support of this discussion. As baby boomers age, the demand for doctors who care for seniors and accept Medicare insurance is skyrocketing. At the same time, the Centers for Medicare and Medicaid Services, CMS, has proposed an almost 3% reduction in physician payments this year, making it the fifth consecutive year of payment cuts. The medical community maintains that inflation, operational costs, and consumer prices have increased while Medicare physician pay has declined. How will another year of Medicare physician payment cuts impact patients? What are the implications if payments to doctors fall below the cost of delivering care? How do rising inflation, labor shortages, and the demand of an aging population affect medical providers? What impacts do these pay cuts have on the broader healthcare system? And what should Congress do? Today, we will examine these questions and more. Before we get underway, one housekeeping note. Please join the conversation on social media. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag TheHillHealth. And with that, I'm pleased to introduce my first guest, Republican Congressman Greg Murphy of North Carolina, co-chair of the GOP Doctors Caucus. Dr. Murphy has also introduced bipartisan legislation to preserve Medicare for patients and doctors. Welcome, Congressman.
Good morning.
Good morning. So recently you reintroduced your bipartisan bill, the Medicare Patient Access and Practice Stabilization Act. Where do things stand with that?
Well, we are right now gathering co-sponsors. I think we're over 90 plus Republican and Democrat. This is a bipartisan issue, at least in the House. And we're moving forward. I'm having discussions with our Speaker and with the White House of making sure that this gets done soon, hopefully in the CR, because truth be told, we're at a deadline. We are at a crucial point as far as funding for physicians, and if not now, when are we going to get this done? So I'm very optimistic we're going to get this done soon.
What is the biggest challenge to getting this bill passed currently?
There are a couple different challenges. One is funding, which is a relatively small amount. I think this is less than $4 billion, which is a lot of money. It is a lot of money, but in the grand scheme of things, a relative small thing. But sadly enough, physician pay has become now a partisan issue, at least over in the Senate. And we have a couple of folks over in the Senate, Senate Democrats to be precise, who are not really crazy about the throes, the difficulties that physicians are facing right now. I think there is a political issue almost as much as financial about with the direction of medicine. And so these are really hills that need to be climbed.
There's a $20 billion check for when Medicare has to be budget neutral. The AMA has suggested raising that. Is that something you feel could go towards supporting the spirit of your bill?
We actually have legislation to raise that. We submitted it last Congress to raise the limit from 20 million up to 50 million. There needs to be that window that they can work with when CMS calculates utilization, or when they look back and say, well, what happened in the last period of time? It doesn't need to be only $20 million. It should go up to 50 million, because truth be told, CMS and a lot of the utilization services that happen around Washington, D.C. oftentimes are wrong as often as they're right. So there needs to be a bigger cushion. So no, we have legislation already to do that. I'm glad to hear the AMA is supporting it.
You are currently the only practicing surgeon in Congress at the moment. What do you hear from your colleagues who are practicing medicine about the fifth consecutive year of payment cuts?
Well, I hear a lot, and that I still practice because I love doing it. I love my patients, but it also gives me an on-the-ground viewpoint from what's happening in medicine. Sadly enough, and at least as sadly to me, what has happened really with the ACA, it's driven more and more and more physicians into employment. Because heck, I ran a private practice for years, and this actually happened in my practice, where you're fighting around to find where the paper clips are to make sure you can keep the lights on. Going into hospital employment, the hospitals have been plussed up all this time while physicians have been continued to be cut. So, there's a great deal of angst that's going on. I'm soon to be 62. I'm still practicing, but a lot of my colleagues who are my age, who are in the private world, are just saying, I'm done. I'm enough with this. Younger folks are jumping into employment, which in my opinion is fine, but I think it's a less efficient, a more costly avenue of dealing with medicine. And sometimes there's not as great an ownership of patient care as would seen in the private world. So there's a lot of angst that's going on, primarily in the practice and private community, but also in employed communities, because again, that's a revenue source of how physicians get paid.
Right. And uh, to add on to that, what are the implications if payments to doctors fall below the cost of delivering care?
Well, I think the nuclear option is that we won't take care of Medicare patients anymore. You know, if and people don't understand this. I've had patients come in and apologize to me when they get their bill from Medicare and see what I'm paid for the services that I delivered. I've had them apologize to me because of that. So you'll either see retirements, you'll either see people just go into employment, which and vertical integration, which I believe is killing this country, or you're going to see more and more and more doctors say, "Sorry, I'm not accepting Medicare." And when surgeons start to do that, that is going to be the bellwether. That's going to be the canary in the coal mine that Medicare is no longer working to preserve access for seniors.
And physicians are saying that the costs of labor and
Yeah.
the burdens of an aging population, what are the burdens that physicians face that frankly make it incompatible with, cutting Medicare costs year by year, Medicare pay?
Yeah, well, look at what's happened with inflation over the last 4 or 5 years. It's skyrocketed, and that's in every facet. That's energy costs, keeping your light bills paid, making sure that your staff is paid because there's a shortage of healthcare workers, and they get a chance to compete. So it's more and more money that goes to paying staff. Lots of all the other different things. Medical inflation, sure, way outpaces regular inflation, how much it costs for syringes or even medications, all these things that go into the mechanics of how you deliver care in a private setting or in an employed setting. But for that matter, the inflation component added to just the fact that you're getting cut for E&M codes is destroying your ability to deliver care, especially in a private practice setting.
We've discussed raising the threshold for Medicare budget neutrality, your bill just for inflation. What other actions can Congress do to ensure that physicians can continue providing care to Medicare beneficiaries?
Yeah, well, Medicare Advantage is one of the things that I think was started out with a good idea, but we're seeing abuses, and you see this in the Wall Street Journal, you see this in so many publications we've had absolute ridiculous abuses in the system. I think they may not be fraudulent, but I believe they're immoral. In some of the Medicare Advantage plans that are upcoding, they're data mining after a patient has been taken care of by a physician, throwing literally hundreds of billions of dollars of waste into the Medicare system. In that same avenue, the pre-authorization, the denials that we are getting is really, they're skyrocketing in and of themselves. And so all of these facets, not only the cost of just paying for your staff and everything else, but then having to hire more staff to fight denials, we're working on all of these parameters to make sure that physicians are actually spending the time doing what we're supposed to be doing, and that's taking care of patients, not worrying about how to pay the bills and not worrying about all the extreme frivolous denials that we are facing.
How have these cuts impacting, you've mentioned, uh, it just competes with the costs of running a practice. But, what are the true material impacts when it comes to physicians and their staff as well?
Well, you're learning to try to cut costs at every juncture to try to make sure you can pay the staff. Trying to keep staff on so that they're not, running to another practice just to get more money. It's a difficult, difficult time. And when I was running a practice, this is what I faced. But we're really at a crux. We're at a crucible where, gosh, if we don't fight these cuts now and we don't get them reversed, I don't see how private practice survives. Some want that. Some are pushing for the single payer system, and this is where some of the opposition comes, especially from Senate Democrats. They want a single payer system and to forcibly push physicians into that type of employment model. But it's just it costs more. It's a less efficient part of care, and I personally believe there's less ownership from physicians. And so you're hearing this all around in every avenue. I'm in the surgical lounge. I'm talking with other doctors about patient care. It's a major, major issue right now.
a huge trend we've seen in recent years is that private practices are essentially going out of business. They're kind of becoming this endangered species of a business. Can you speak to, what other actions Congress can take to protect private practice? Because it does seem to be another aspect of the healthcare community that is under attack.
Sure. If you look at what the ACA was doing and all the push that it's done so much to give insurance companies control of what's happening in healthcare. And when they're doing this, they're cutting reimbursement to physicians for services that we're paying. They're following the Medicare model in the same way. But insurance companies also, you've seen a skyrocket in the number of denials that they go into. We're putting a lot of effort into that. We need to reform Medicare Advantage. We need to reform the denial and pre-authorization process. There's no way whatsoever if I get denied or if a patient gets denied a service or a medication that I've recommended, that I need to talk to a pediatric oncologist or a nurse practitioner about what's going on. We need a peer-to-peer review process. We also need one, somewhat of a gold card system. I think Representative Burgess put that out last time, that if physicians are really doing it right, they're not ordering a lot of tests, they're being appropriate about that, then they're not pushed on as far as denials and authorization issues. There are a lot of things that we are doing to try to make the world of private practice still tenable. There are a lot of forces that, again, want to push us into a single payer system, which I think is wrong for everybody.
Would you be able to expand a bit more on how rising inflation and how bad labor shortages are currently for, physicians such as yourself or others in the community who are trying to continue to provide care for Medicare beneficiaries?
Sure. The first 15 years or so that I was in private practice, we had people, staff members that had been with us the entire time, all 15 years. Now you're seeing a much more transitory environment where people are jumping from job to job because, hey, all of a sudden now that person will pay me more, or I can go and do something else. We're seeing a shortage in so many different fields, ultrasound techs, CNAs, a lot of different things where we're having folks who are not coming into the healthcare system. And so that shortage of supply with an ever increasing demand is really causing wages to go up. We're having a real difficult time, not only with recruitment, but retention, and really trying to take care of our employees, not only through salary, but some of the other benefits that we deliver to them is going to be critical to keeping a defined workforce, one that stays. If you look at all the different parts of inflation, medical inflation, it's ridiculous what some of the medical device companies charge us for some instruments and some of the other things that go on. There really needs to be a full reset, and I'm glad we're hearing that word say a lot here in Washington, D.C., of where medical costs are going. Now, some of it has to do with physicians not ordering too many tests, which I blame on some of my colleagues and the mid-level providers too. But we also need to look back and say, hey, what is a reasonable cost for a lot of things that go on with medicine? Some of the device companies and other folks really need to have an accountability to that issue.
All right, well, thank you so much. That's our time. Thank you again, Congressman, for joining us today to discuss this important topic.
Great, thank you.
Thank you. Next, we'll hear a word from our sponsor, the American Medical Association. Please welcome my colleague, Sarakshi Rai, Director of Audience Development at The Hill. She's joined in conversation by Dr. Bruce Scott, President of the AMA. Sarakshi?
Dr. Scott, thank you so much for joining us today. Please tell us the state of the Medicare physician pay and how it compares to other healthcare providers.
It's actually quite a problem because Medicare pay to physician practices, believe it or not, has actually been cut over 30% since 2001. And as a result, patients are having increasing difficulty getting in to see their doctor. Can you even imagine getting paid 30% less now than you were paid 20 years ago for the same work that you did back then? Physician practices are struggling, and practices like mine are really having financial difficulties. And in some cases, they're actually closing their practices.
And so how will the latest Medicare physician payment cut, which is the 5th consecutive cut, impact patient access to care?
Undoubtedly, what it's going to do is make it more difficult for patients to get appointments to see their doctors. People don't necessarily think about physician practices as a business, but if you run a business and your revenue goes down every year, 30% in 20 years, at the same time your costs are going up, at some point it's unsustainable. And a recent survey showed that 1 in 5 physicians are actually actively looking to leave practice within the next 2 years. And we already have a physician shortage. Some estimates are as high as an 80,000 physician shortage in the coming year. Now, think about the fact that it takes 8 to 10 years to train a new physician. And yet, there are a lot of practices that cannot sustain even one more year of these cuts. We can't afford to lose even one more doctor. And this crisis is upon us now.
And we already see that, with just the delays with people getting appointments. So how do these cuts really impact the broader healthcare system beyond just the Medicare beneficiaries?
Well, this affects all patients because you see the private payers, they're well aware of the fact that there's a downward continual spiral of Medicare pay. So as a result, they've tied their payment rates to the Medicare payment rate. And as a result, that magnifies the problem. So this isn't just a problem for Medicare patients. Your doctor, your parents' doctor, heck, even your pediatrician needs you to add your voice to tell Congress that they need to fix Medicare and they need to fix it now.
And so what do you see for the future of your practice if this issue is not addressed?
Well, frankly, financially, it's become almost a month-by-month situation. In fact, in my own small practice here in Louisville, Kentucky, 2 of our physicians have left at the beginning of this year, and 1 more is looking to leave. And I'm hearing that as I travel across the United States, as more and more physicians are struggling. A close friend of mine who's an obstetrician in a small rural area closed her practice in October because she could no longer financially survive. And frankly, her spouse was tired of supporting her practice with his income. She tearfully sent a letter to all of her patients saying, at this point, I can no longer sustain my practice. She's torn up about the fact that she doesn't know where those patients are going to go to get care. And this is happening. This is not some hypothetical situation. This is real. And as a result, patients are suffering.
And so beyond canceling that 2.83% cut that went into effect this year, what else can policymakers do to improve the system and safeguard care for their constituents?
Well, maybe the good news is that a group of 10 legislators, bipartisan legislators, this year have introduced a bill. Technically, it's called H.R. 879, the Medicare Patients and Physician Access to Care Act of 2025. What this legislation would do is roll back the cut that went into effect January 1st, and it would also provide a 2% positive update for physicians starting in April. Now, here's a couple challenges. It has to be passed before the end of March. So that's why we really need the patients of America to reach out to their legislators and say that they need to fix Medicare now. We've created a website, which is simply fixmedicarenow.org, which patients can go to, and they can see resources there in order to contact their legislators. And we need to do this now. Part of the other problem is that even Medicare's own prediction is that costs this year are going to go up 3.5%. So even if we get this 2% bump, it's still not enough for physician practices to keep pace with inflation. So ultimately, the American Medical Association is pushing for legislation that would simply tie physicians' expenses and physician payment together. This isn't some radical idea. Hospitals, long-term care facilities, ambulatory surgery centers, and other providers in Medicare already get this inflation-based update. Physicians are the foundation of healthcare. Doesn't it make sense that Medicare should adjust the payment to physicians at least to keep up with inflation so that we can keep our practices open?
All right, Dr. Scott, thank you so much for being today and for your insight. We appreciate it. Thank you.
It's a pleasure to be here and helping to spread this important message.
My next guest is Congressman Jimmy Panetta, a Democrat from California and member of the House Ways and Means Committee. Along with Congressman Murphy, he is the co-sponsor of the Medicare Patient Access and Practice Stabilization Act. Welcome, Congressman.
Thank you. Appreciate this opportunity to talk about something that's very, very important in my district in the Central Coast of California.
Absolutely. You sit on the Ways and Means Budget Subcommittee. You recently called the majority's resolution a threat to working families, seniors, and students. Can you tell us on what the state of the current showdown is?
Yeah, look, I think obviously with the budget resolution that sort of sets out the framework for a reconciliation budget package, what they called for were a tremendous amount of cuts. And that's why I said there's potential for it to be a real threat to working families, especially with programs like Medicaid, student loans, student lunches, Head Start, and so forth. And so people need to understand that, especially the public, that although it may sound good to have tax cuts or tax cuts for billionaires, the fact is that the Republican majority and Speaker Johnson want to pay for it with these types of cuts. So that reconciliation resolution package passed out of the Budget Committee, and I voted against it. I actually offered a couple amendments to make it a little bit better. Those were all voted down by the Republican majority on the Budget Committee. Then it went to the House floor, and it barely passed by one vote. Now what you're seeing, because that resolution ordered the committees to then either have cuts or the Ways and Means Committee have a certain amount of spending, that's where the committees are going to be working on from here on out. So that's the process. Passed the committee, the Budget Committee, it passed the House. We got the framework. Now the artwork starts to be filled in the frame through each and every committee.
One area where there isn't too much divergence is the need to stabilize Medicare physician pay, which is why you introduced this bipartisan bill with Congressman Murphy. How hopeful are you that it's going to pass with the current state of Congress as it is right now?
Yeah, well, that's kind of a two-part question there. One, I believe in my bill, especially having an excellent partner like Dr. Greg Murphy from North Carolina, the bipartisan bill, the Medicare Patient Access and Practice Stability bill that would offset the 2025 Medicare cuts by 2.8%. And then take into account inflation and basically adjust those types of Medicare reimbursements by 50% for at least 1 year, which is a smart thing to do to kind of bring down cost. So it's close to 71 bipartisan members supported it last term. Hopefully we'll get more members on it this term because I think everybody understands the fact that Medicare is not keeping up with inflation. It's clear in my district, it's clear in Dr. Murphy's district. That's kind of the norm throughout the country, unfortunately. So we have to do something to ensure that the reimbursements are basically upped. And this is one solution that we hope we'll be able to get in any future package going forward, not just the reconciliation package, but possibly if there are negotiations, which there should be, in regards to the budget that comes due on March 14th.
In your view, why has physician pay become kind of a political issue now?
Well, I wouldn't say it's a political issue because this is so bipartisan. It's just what type of vehicle it gets tied into that can be political. Now, trust me, if it gets for some reason tied into the reconciliation package, and if the Republicans in a very slim and splintered majority can actually agree on something, hey, that's fine with me. I'll probably still vote no on the entire package because there's going to be so many cuts. At least that's what they're portending with the fact that the resolution had significant amounts of cuts in Medicaid, potentially even Medicare. And so that's going to be a real issue. And one of the main reasons why I'll probably vote no, especially if it's a partisan process. But look, like anything, if they want to negotiate, if Republicans want to negotiate with Democrats, we're more than happy to do that. And one of the things I will push for is the Medicare Patient Access and Practice Stability Act, a very bipartisan bill that, as I explained, basically will offset the 2025 Medicare cuts of 2.8%, and then it will basically tie it into inflation, or at least make sure that the reimbursements are at 50%. Look, why it's such a bipartisan issue is because, as we're seeing, it's Medicare reimbursements are not keeping up with inflation. In my part of the woods in Central Coast of California, it's one of the most expensive regions to provide care because it's about dealing with operational costs. It's about dealing with rent. It's about dealing with wages. It's about dealing with insurance. And those prices have gone through the roof. And unfortunately, these types of reimbursements aren't keeping up. And so what you're seeing is doctors who are already up there in age basically saying, I'm done, I'm out. I cannot afford to continue my practice. Or if I still want to practice and I'm still young enough to practice, I can't do it here in Central and Northern California or in California. It's too expensive. So they leave, unfortunately. And that's been a real issue. Spoke with hospital heads who have literally provided new doctors, not just cars, but houses, because housing is obviously so expensive on the Central Coast of California. A year later, those doctors have turned in those keys to those houses because they just can't afford to live there, and mainly because reimbursement rates for Medicare are not keeping up with inflation, and we got to fix that, and the Medicare Patient Access and Practice Stability Act would.
You mentioned doctors being priced out of the profession or a practice. You've been very active in trying to address the country's physician shortage, especially when it comes to treating Medicare patients. What have you learned in regards to what needs to be done to sort of, counteract this trend?
First and foremost, we got to up the reimbursement rates. Cannot stress that enough. They have to match the inflation. And that's exactly what Dr. Murphy's and my bill would do. Secondly, you got to offset those cuts that unfortunately were just created when Medicare was created. And right now we're looking at a 2.8% cut that came into effect in January of 2025. And so those are the two most important things to do. Third, you got to start thinking about general practitioners. I had a Medicare roundtable about a month ago in my district, and all of the hospital heads and doctors that were at that table basically said the GPs, our general practitioners, are just not coming out of medical school. They're having to specialize. Why? Because general practitioners aren't getting reimbursed enough when it comes to Medicare and even Medicaid. And so this is a real issue, especially when you start talking a reconciliation package that has significant cuts to either Medicare or Medicaid. And so this is something we want to stop. And our bill would at least kind of put a Band-Aid on that for now, at least for the next year.
You also recently introduced a bill to expand coverage for chronic diseases, and that is something that is a focus for the current administration under our current HHS secretary. How do you expect chronic illness and healthcare at large to be impacted when we're talking about this issue of Medicare physician pay being cut every year?
Yeah, look, I think we can walk and chew gum at the same time. And obviously, when it comes to healthcare, we're getting to a crisis stage at this point. When you're seeing cuts in Medicare, when you're seeing potential cuts in Medicaid based on their Republican reconciliation package, when you're seeing people with chronic diseases not have access to these doctors. And so that was the purpose of the bill that I spoke on the floor this week in regards to the bill with Vern Buchanan, who's the lead author of the bill. I'm a co-lead of that bill to ensure that those people who have chronic diseases have more access, not just to doctors, but to insurance and to care going forward. So it's something where we have to realize that it's kind of an all of the above approach, especially when it comes to healthcare in the United States of America and the downward trajectory that we're looking at with those areas that I just discussed. And we need to step up as a body, a congressional body, a legislature on the federal level to ensure that it's fixed. We need to do that for Medicaid. We need to do that for Medicare, and obviously those with chronic diseases as well.
And while we're having this conversation, DOGE is also currently, making its way through the federal government. Do you think an effort to stabilize Medicare physician pay can coexist with this current effort to root out, waste, fraud, and abuse?
Look, with the right advocacy, I think anything can take place. And, I'm an optimist. I have to be in this job, especially with everything we're dealing with these days, including Doge. And the fact is that if you have Republicans and Democrats coming together on a bill like the Medicare Patient Access and Practice Stability Act, I believe it's something that hopefully those in the administration will listen to, especially when you look at access for seniors when it comes to Medicare. So even though you have someone like Elon Musk who wants to go in there and take a chainsaw, a sledgehammer, or TNT to many of our institutions, to many of our agencies, or to many of our plans, be it Medicaid or Medicare, you have to work hard to convince them that it's a wrong thing to do. I was just had a meeting with my staff earlier, letting them know that we have to be a little bit proactive in thinking outside the box when there are certain cuts that affect our district to ensure that the administration hears about it. You just can't sit back and say, oh, there's a cut. What can we do about it? Nothing. No, that's wrong. We're here to represent the people of our districts and fight back. And I will fight for the people of the 19th Congressional District, especially when it comes to Medicare reimbursements, especially when it comes to these types of extreme cuts that Doge and Elon Musk are doing, not just to certain organizations and agencies. But what's going to happen is when they continue to do this, you're going to see government seize up. You're going to see the services that people rely on not get out there. And let me tell you, that's what I'm telling them. That's when you got to hold your representatives accountable. If you have representatives that support these types of cuts, you're going to lose services. And when you lose those services, that's when you better hold them accountable.
Thank you so much for joining us for this discussion, Congressman.
Thank you.
It is now time for our panel. Please welcome Susan Dentzer, President and CEO of America's Physician Groups, Terry Wilcox, co-founder and chief mission officer of Patients Rising, and Dr. Mark McClellan, former CMS administrator and founding director of the Duke Margolis Center for Health Policy at Duke University. Welcome, everyone. Dr. McClellan, you are a doctor and were CMS administrator 20 years ago. What are some of the challenges in getting this reform done that might not be so obvious to the broader public?
Well, it was a little bit easier then. The Medicare spending levels were lower, and it was on the tail of some major reforms in Medicare. We had just enacted the Medicare Modernization Act, which put an emphasis on making care more prevention-oriented, including prescription drugs, and that meant more, not less, interactions with physicians and especially primary care practices. Since that time, as Medicare costs have continued to rise, we've tried a couple of major steps to try to get payments more aligned with the costs of delivering care. And most recently was a set of reforms that implemented a payment system with quality adjustments that also was not tied to growth in overall healthcare costs. So in more recent years, we've seen growing interest in trying to find ways to get the payments more aligned with spending growth, but it's become increasingly hard as Medicare spending is higher and the actuaries, the technical experts that add up how much this costs show that it adds to spending. So we've gotten back into this old habit of Congress having to step in every year and at the last minute try to fix payments, and they're in the process of doing that again right now. I do think there's a chance to shift that by moving to different ways of paying for physician care. And at this point in Medicare, more than half of people are in Medicare Advantage plans that don't just pay on a fee-for-service basis, but try to support coordinated care for people. And even in the traditional Medicare program, most beneficiaries are in what are called accountable care arrangements, alternatives to traditional fee-for-service payment. So I do think there's a solution, and it's great to have another physician coming in to head CMS at such an important time. I do think there's some solutions in the direction of, hey, not just sticking with fee-for-service payments that are never keeping up, but supporting physicians, both primary care physicians and specialists in helping to drive into these more effective, prevention-oriented, coordinated, simpler payment models. So that should be part of the solutions going forward.
Gotcha. And, we're focusing on, physicians and their ability to stay in practice. Susan, you represent physicians. Can you speak to the current challenges they're facing and what their biggest concerns are as they face a fifth consecutive year of Medicare physician pay cuts?
Absolutely. And the 360 physician groups that we represent are committed to value-based care. They're committed to being held accountable for the cost and quality of care. So all of them are participating in some of the alternative payment models that Mark was referencing, as well as heavily in Medicare Advantage. Our groups care for about a third of all the MA enrollees in the country. What has happened since 2001 is that the Medicare physician fee schedule, which we should note doesn't just pay physicians, right? It also pays nurse practitioners who bill through Medicare, physician assistants, clinical psychologists, and others. Because there's no automatic inflation adjustment and accommodation for practice cost inflation built into that fee schedule, in real terms, inflation adjusted terms, it's fallen by about a third in terms of its level of payment to physicians. Now, payment is a function both of the payment level and the provision of services, right? So to some degree, our sector is compensated by just supplying more services. So even if you're paid on a unit cost basis, if you're doing more services, you can manage to hold your own. But that's not an optimal situation. We want the best care for the right patient at the right time and in the right amount. So what has happened again is that without this inflation adjustment, the effect of the fees in the fee schedule, they have fallen in real terms. They have put physician practices and others in the position of having to try to make it up on volume, if at all possible. And we're very heartened by the fact that there are voices now suggesting not just addressing the latest cut in the fee schedule that is in place now for 2025, but also incorporating into the fee schedule an inflation adjustment that will take account of this almost automatic increase in costs for physician practices that has occurred from year to year. That has basically, it's important to note that most physician practices now across the country are under serious financial pressure from rising rents, from rising labor costs. We know that labor costs have risen substantially. There are labor shortages across the healthcare workforce. And all of that poses an extreme amount of financial pressure on physician practices. Many of them can barely keep up with the demand that they now face, let alone the demand that they expect to face, particularly from a growing Medicare population, especially the part of the population with multiple chronic illnesses, lots of healthcare challenges, and frankly, getting older. So a real quandary for physicians at this point. And that's why we're very, very hopeful that we'll see two things happen in the near future. First of all, a rollback of the almost 3% physician fee cut that is scheduled, that is already in effect for 2025. We would like to see that eliminated. And we would also like to see an inflation adjustment incorporated into the Medicare physician fee schedule going forward.
And Terry, you work in patient advocacy. At the end of the day, this is all about making sure that patients get the care that they need. Can you speak to the implications of whether this trend continues? Obviously, there are concerns that there won't be enough physicians, they'll be priced out, but it goes beyond that, doesn't it?
Well, definitely. I mean, patients are the ones who ultimately feel the impact of these cuts. I mean, it actually falls on the shoulders of patients and their caregivers. It's not just the doctors. So when physicians can't afford to see Medicare patients or having to make it up on volume, as they say, so they don't have as much time, access suffers. I mean, as somebody who has taken care of seniors over the past several years through COVID, and I had 3 and now I'm down to 1 as of the beginning of this year. But I can tell you, as somebody who makes those appointments, who works towards making sure that they have continuity of care, they have all of the things that they need for their prescriptions, et cetera. It can sometimes take several calls, and part of that is just the mass amount of volume that's happening in the physician's offices, and it's also very difficult to get into new physicians. So there is a real physician shortage, I want to say here, already underway. And so then to take this and, add pay cuts on top of that, I think is detrimental to the patients and especially the seniors in this country.
Thank you. And Mark, you were a CMS administrator. The AMA, our sponsor, is in favor of increasing the threshold for Medicare tax or Medicare budget neutrality, which people say is the cause behind these cuts. Is Medicare needs to be budget neutral for under a certain threshold. How do you feel about calls to increase that? We've seen numbers suggesting doubling that or even quadrupling that.
Well, I mean, as you heard from the other panel, I think Terry put it very well. If there's not adequate payment for physician and their teams, then there's not going to be adequate access to care in Medicare. I think that the challenge is twofold. One is increasing the funding so that these payment rates match cost. But I'd like to add to that, as Terry described, the experience of care for a Medicare beneficiary is not easy right now. And I think that's partly driven by the fact that for many physicians, they're still getting paid on this fee-for-service basis where the rates keep getting tightened down. And what you do in that kind of volume system to stay in business is you have to see more patients in less time. And that means it's harder to provide the supports that each of them need. Another component of the bipartisan agreement to try to at least get through this year and get on a better path for physician payment was an additional payment to the physicians and their teams that moved into these so-called alternative payment models that are about paying for the whole practice, like direct payment to a primary care group to build out the data infrastructure and bring in more team-based approaches to care, to use digital technologies and AI and telehealth, the other things that Medicare traditionally hasn't paid for very well, if at all. That would be an additional sort of 3.5% under the bipartisan agreement that we have now for the next year, and that would be actually expected to be paid for by savings that would come from not having to have as many patient visits in person and having better support for coordination of care and just more convenient and efficient ways of delivering care, like many of Susan's member organizations are participating in right now. So I don't think we can get the budget numbers up enough just by paying more in fee-for-service, especially with so many examples today of physicians who are doing better by moving away from that fee-for-service, hamster wheel.
Right.
Right. I would just jump in and say we concur with that. We think payment has got to move along two tracks. As long as there's a traditional Medicare program, a lot of providers will be paid through the fee schedule. And keep in mind, many of the alternative payment models are still based on classic Medicare fee-for-service payment. So as long as that end of the world exists, and we think it will for a while, we've got to continue to improve the functioning of the Medicare physician fee schedule, as Mark said. And that, by the way, can include adding new features to the fee schedule, not just addressing budget neutrality, which is probably appropriate, but also adding new features into the fee schedule that could put resources in the hands of, say, primary care practices that they can't now get through the fee schedule. The second track, though, that the nation is clearly following, and our groups are certainly following, is taking on patients in Medicare Advantage and being paid in particular for our groups directly by plans who are delegating a lot of the risk over to our groups, and then they get the resources that they need by virtue of risk adjustment and other features in Medicare Advantage to actually produce the kind of advanced primary care strategies that are so critical now to taking care of an older and sicker Medicare population. So we definitely agree. We need those two tracks. And as long as we have them and continue to support them, we'll be able to deliver the kind of care that ideally the patients that Terry references would want to have.
Right. And turning to Terry, we're talking about alternative payment models. To your knowledge, are people, made aware of these alternative options that could be available to them Is there an outreach for that? Do they, are they being told of that?
No, I mean, I can tell you as somebody who goes to many appointments, who takes care of seniors, it's really just about, it's a fill out this form, it's a check in, in my personal experience and in the seniors that we talk with, there isn't a lot. But one of the things that we advocate for and we think about a lot at Patients Rising is many of the things that we've talked about here, which is seniors and people with chronic conditions in general, they need a continuity of care and, not a revolving door. And they need plans and doctors and practices and everyone, Medicare, CMS, to think about the long-term health and well-being of a patient and not just an annual, insurance, because our system is set up where we think about the long-term health and well-being of someone for 12 months, and then we start over again, right? And so I think patients are not made aware of those payment models, at least in my experience, but I think, seniors would definitely be open to that. I know I would be open to that because my mother-in-law, my stepmom, now my mother-in-law just passed away at the beginning of the month. My stepmom lives with Alzheimer's, and there's a lot, of things to manage for that. And it's not just on an annual basis.
Thank you. Lightning round of questions, starting with Susan, and then we can go to Terry and Mark. What does comprehensive Medicare payment reform mean for the groups you represent or the people you work with? Susan?
Well, it's going to happen in stages because that's the way Congress will address these issues. Number one, we need to see a rollback of the almost 3% Medicare physician fee cut in this year. And we would second Mark's reference about the need to restore the advanced alternative payment model bonuses, which are frankly gone now for this year. So putting those back on the docket, in effect, restoring those AAPM bonuses and also redressing the fee cut is essential. Beyond that, we need to revisit the 2015 MACRA law, as it was called, to examine some of these features of the fee schedule that we think need to be fixed, and in particular, addressing the inflation update, as I said earlier. But more broadly, we're in favor of pushing as far as possible toward alternative payment models. So that could potentially mean dismantling other aspects of what was put in place in 2015 in MACRA in order to speed up the transition to alternative payment models, because we fundamentally agree that more population-based payment in the system as opposed to fee-for-service-based payment is the way to go. And that with true accountability of physician groups on both the cost and the quality, we can deliver superior outcomes for patients.
Thank you. Terry, what does this mean for your group?
Well, I agree with everything Susan just said, as far as, we need to take care of this, because at the end of the day, the people I represent, which are the patients, they don't need more hurdles to care. They need doctors who can afford to see them. And so ignoring this problem, it's as I said at the beginning, it's patients who end up paying this price. So that is where we sit. We believe Congress needs to act on this and move forward for patients. Medicare is supposed to be a promise. It's a promise to access care when you need it. And right now, that promise is breaking for many seniors in this country. So thank you.
Mark, from policy standpoint, what does this Medicare payment reform mean for you?
Well, look, and we see this in our work at Duke Margolis on helping to support better policies. These changes that we've talked about are badly needed, and they're hard for physician groups that are stretched right now to undertake. But we have seen a growing number of successful examples of physician practices that are moving in the direction of using team-based care and digital and AI technologies and ways of coordinating with community-based providers, providing relief for some of those caregivers that we just heard about. and you have to change the way we pay to get there. So the challenge is, how do we do that at the same time as we're helping the providers along? I do think, we haven't had that many physicians or clinicians leading CMS in its history. My expected successor, Dr. Oz, is coming in with this perspective very much in mind. So now's a great time to build on the successes of the past with the urgency to get to a more sustainable but more effective non-fee-for-service based healthcare system.
Thank you, Mark. And thank you to all of our panel for joining this discussion today. Susan Denser, President and CEO of America's Physician Groups, Terry Wilcox, Co-founder and Chief Mission Officer of Patients Rising, and Dr. Mark McClellan, Director of Duke Margolis Center of Health Policy at Duke University. Thank you all for joining us.
Thank you.
Thanks for having us.
Thank you.
That brings us to the end of our program. Thank you to all of our wonderful speakers. On behalf of The Hill and our sponsor, the American Medical Association, we'd like to thank everyone who joined us today. Thank you very much and have a great rest of your day.